Good afternoon. I would like to welcome you to our mini symposium on health education and healthcare disparities, a critical look at an interdisciplinary approach to diversity, equity, and inclusion. First, we will have opening remarks from Dr. Maurie McInnis. President McGinnis, a renowned cultural historian of the 19th century American South, became the 6th president of Stony Brook University on July 1st, 2020. As chief executive for Stony Brook, she also oversees Stony Brook Medicine, Long Island's premier academic medical center, which encompasses 5 health science schools, 4 hospitals, and 200 community-based healthcare settings. Since her arrival at Stony Brook, President McInnis has been focused on enhancing collaboration between the university and the Stony Brook Medicine as one campus, developing greater appreciation for the special role Stony Brook plays as an AAU institution within the state and State University of New York system, and ensuring Stony Brook's long-term financial viability. Before coming to Stony Brook, she served 4 years as Executive Vice President and Provost at the University of Texas at Austin. Prior to that, she spent nearly 20 years at the University of Virginia in various academic and administrative appointments, ultimately as the Vice Provost for Academic Affairs. One of President McInnis' most significant accomplishment at UT was broadening interdisciplinary collaboration in education and research across the entire campus. At Stony Brook, she is creating opportunities for students to engage in important real-world research while bringing economic growth to the region through the university's partnership with nearby Brookhaven National Laboratory, a U.S. Department of Energy facility. Equity, diversity, and inclusion in higher education has been career-long priorities for President McInnis, and she has a demonstrated track record in fostering significant investment in these areas. At Stony Brook, she has assembled a team that reflects diverse talent and people with varying viewpoints and area of expertise different from her own. She seeks to strengthen Stony Brook's impact in driving intergenerational socioeconomic growth and preparing students for success after graduation. I now give you President McInnis.
Well, good afternoon, and thank you all for joining us today at this important symposium, Health, Education, and Healthcare Disparities, a critical look at diversity, equity, and inclusion. Stony Brook University was founded to provide quality education and more opportunity to a growing, diverse population on Long Island. Our hospital was born out of a need for better healthcare education and critical shortage of healthcare providers in New York State. This university accepted those challenges and grew to become one of the leading academic medical centers in the country. In the 50 years since the founding of the Renaissance School of Medicine, we have grown to reach over 1 million outpatients and cultivate countless partnerships within our community. The pandemic year has laid bare the fact that a dynamic, successful society cannot exist without comprehensive and accessible healthcare. In 2021, we must continue to adapt and enhance our medical enterprise for a new era. Now, it is imperative that we consider in what ways we must improve to ensure the wellness of our large community and move society in a more equitable and inclusive direction. I'm grateful to report that we have many programs focused on this goal. This September, Stony Brook hosted the Long Road to Equity for Women in Medicine, an international conference that looked across disciplines, from psychiatry to neurology, emergency medicine to social welfare, to track the origins of gender-based healthcare gaps and search for more concrete solutions to improve the health of women across the world. Through the New York State Birth Equity Improvement Project, the Stony Brook Medicine perinatal team has committed to doing critical analysis of how systemic racism impacts birth outcomes at our facility. Though this information is unfortunately not new, the recent data alone on the systemic inferior perinatal care for Black women serves as an urgent call for healthcare providers across the country to seriously reevaluate and implement new practices that serve all women and mothers everywhere. Our perinatal team has committed to actions in the areas of standardized care, collection of perinatal data, patient experience ratings, and decreased nulliparous, term, singleton, vertex, cesarean birth rates to improve the outcomes for Black mothers in the communities we serve. This past year, I have spoken more than once about the importance of representation across industries, disciplines, and departments. An equitable, diverse, and inclusive society must see its own needs reflected in its leadership. An equitable, diverse, and inclusive patient care starts with providers. In keeping with this effort, Stony Brook's pre-medical access to the clinical experience, the PACE program, a collaboration with Old Westbury, assists underrepresented minority students in matriculating to medical school. In providing Kaplan, CARS, MCAT prep, it is our aim to build a more diverse and equitable health landscape by supporting underrepresented students, our future doctors, nurses, and health experts, to achieve their goals and reach their potential. This afternoon, you'll hear from Associate Professor Jennie Williams on erasing health inequalities, Assistant Professor Hector Alcala on racial and social determinants of health, Clinical Associate Professor Lisa Johnson on creating inclusive and equitable learning spaces, and Assistant Professor and Founding Director of the Mind-Body Clinical Research Center, Adam Gonzalez, on promoting diversity, equity, and inclusion at Stony Brook Medicine. I look forward to hearing from all of these experts and to learning more about how Stony Brook can best offer its world-class health education and care to our large, diverse community of neighbors, friends, and family. Thank you.
Hello. So I'm up first, Jennie Williams. And my talk, as stated before, is erasing health inequalities. Today, I would like to draw a line between the lack of diversity in STEMs and disparity in health outcomes and how this is associated with health inequalities. The 4 talks today will end with approaches to address this issue at Stony Brook. My research focus is colon cancer, so when I refer to health disparity, that will reflect that focus. So here in this slide, this is a snapshot of the lack of diversity nationally among chemistry faculty. This slide is specific for chemistry, but the trend is similar for other STEM fields. It is important to note here that although 4.6% of PhD recipients are African American, less than 2% are professors. This should be taken into context with African Americans making up 13.3% of the U.S. population. This trend is also the same for Hispanic Americans. Additionally, although 1/4 of New Yorkers are African American, fewer than 6.3% of our doctors are. This absence of African American doctors contributes to the ongoing health emergency of non-white New Yorkers and provides the argument for workforce diversity through education, specifically starting at the elementary and high school levels. The overall prevailing thought is that diversity makes better science. Specifically, both equity outcomes as well as knowledgeable production in the sciences are enhanced by attention to cultural diversity, specifically diversity of ideas, methods, population, and site of specific practice. Health disparity has been attributed to inherent cultural differences, socioeconomic disparities, and race as a genetic factor. When we control for the first two, disparity still persists. The latter, race as a genetic factor, has been debated, with one camp favoring inheritance and another favoring the triggering of factors via social determinants of health. There are several factors associated with health disparity. We know that the incidence of and mortality from cancer is more acute for racial and ethnic groups. However, most of our knowledge of tumor biology and chemo response is based on studies using Caucasian American in vivo and in vitro models, assessment models. However, some studies have shown that African Americans with colorectal cancer have higher frequency and unique single polymorphisms in genes such as KRAS and P53. In addition, some of these differences are associated with limited response to standard of care agents such as 5-fluorouracil. Addressing health disparity is limited by the lack of available data generated using diverse samples and diverse assessment models. In NCI, National Cancer Institute's Cancer Genome Atlas, data available for genomic analysis of African American is less than 9%. And in ATCC, where we acquire our cell lines, there are 0 colon cancer cell lines designated as African American. In a one-site study using, after controlling for tumor location and pathologic stages, a decreased overall survival at 5 and 10 years post-colorectal cancer surgery for African Americans compared to Caucasian American was observed, suggesting overall survival post-surgery may not be attributed to tumor stage or treatment, but to differences in biological and genetic factors. Another study compared the colon cancer rates between African Americans who a diet of low fiber and high fat with Africans in rural South Africa. Their diet consisted of high fiber and low fat. Incident rates were found to be higher for African Americans. Once they did a 2-week food exchange diet, it resulted in reciprocal changes in mucosal biomarkers of cancer risk and in aspects of microbiota and metabolomes known to affect cancer risk. This suggests the triggering of inherent factors and the importance of diet as a risk factor. My research efforts started out in colon cancer chemotherapy and moved into cancer health disparity when I was unable to find diverse colon cancer cell lines. Specifically, we are looking at genetic and epigenetic differences, differential microbiota profile, and how these factors affect chemotherapeutic response and resistance. Here we correlate high expression of granzyme B with overall survival. In our study, granzyme B expression was higher in Caucasian Americans than in African American colorectal patients. Granzyme B is a serine protease expressed by cytotoxic T lymphocytes and natural killer cells. These cells are important for the induction of apoptosis or cell death. From our tissue samples, as I stated, results demonstrated the expression of Gram Z was higher for the Caucasian Americans. This slide itself was generated using data provided by the Cancer Genome Atlas. Here, in Caucasian patients only, high expression of Gram ZB did not correlate with better outcome, whereas in African Americans patients only, high expression correlated with better outcome. However, when compared as one group, higher expression did not correlate to better outcome. This emphasized the importance and an important point about inclusion in research as well as appropriate stratification for assessment. So our research study model incorporates how socioeconomic status are social determinants of health affect an individual's microbiome through diet and environment, which in turn triggers inflammatory responses, resulting in genetic and epigenetic changes. These changes result in increased expression of oncogenes and decreased expression of tumor suppressor genes, and ultimately leading to cancer initiation and progression. The final question we pose is whether chemo response is a racial effect. To address these questions, we are collecting blood and prospective colon tissue. Prospective tissues are used to generate diverse in vivo and in vitro models. Samples are used to assess lipidome and metabolome profiles. chemo response, and omic analysis such as RNA-seq, DNA methylation, and 16S sequencing. Clinical data is used to normalize for confounding factors. And I need to point out here that the samples that I'm getting are actually not only from Stony Brook, from other areas as well. The patient population we see here, especially for colon cancer, are very low, so we have to farm out in order to acquire statistical numbers. Okay, so I'm not going to go over all of the experimental approaches, but there are a couple of points that I think that it's important for to note as results from my lab. Our lab results have identified differential DNA methylation patterns, specifically hypermethylation or silencing in promoter regions. As you can see from this slide, specifically for African American, there were 265 hypermethylated genes compared to Caucasians with 24. Also, between Caucasian Americans and African American samples, we demonstrated differences in the number of genes and regulation patterns, the number of genes and regulation patterns, as well as the number of significantly expressed genes in tumor versus normal. So overall, these two results would lean more toward inherent than in acquired disease. So overall, we have shown differences between African Americans and Caucasian American colon cancer patients at various levels, specifically gene expression, microbiota profile, DNA methylation, and chemotherapeutic response. We are continuing this effort to determine or to define those factors associated with cancer initiation, cancer progression, chemo response, as well as overall survival. I thank you for your attention, and I give the podium to Dr. Hector Alcala.
Thank you very much, Dr. Williams. So today I'm here to give you a slight overview of the social determinants of health and why we should care about them here at Stony Brook, as both a campus that sees many students and as a place where people come for healthcare and as a large medical system on the island. So our objectives for today will be threefold. First, define what the social determinants of health are. Also present frameworks that we can use to address the social determinants of health and sort of link to what we can do specifically here at SBU. And then our role for addressing them here. So what do we mean by the social determinants of health? According to Healthy People 2030, the social determinants of health are the conditions in the environments in which people are born, live, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. So here, what we're talking about conditions, we're talking about a broad range of conditions. So we can talk about social conditions like the presence of crime in our environment, feeling unsafe in our surroundings. We can talk about economic conditions, so whether or not we're thriving or we're in a recession, for example, and the physical conditions, so maybe the presence or absence of sidewalks, whether there is lighting, etc. And when we talk about environment, we're usually talking about place and in the physical space sense, so a physical setting that one can exist in. But I would challenge us in the context of the pandemic that we have kind of learned that we're also existing in this virtual space increasingly, and that if we care about the social determinants of health, what happens in this virtual space will also matter to us and should also matter to us. So now let me give you a different definition. So this is from the World Health Organization. So according to them, the social determinants of health are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at a global, national, and local levels. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. So why do I show you this definition? So this definition kind of pinpoints that there's something we can do about this. So these conditions are avoidable and unjust, meaning that we, an institution with power, can do something to address this. So what are some examples of social determinants of health? We might consider access to a myriad of different resources. So we can consider resources to meet our basic daily needs, so access to food, water, shelter, for example. We might also look at educational, employment, and economic opportunities, so whether or not they're present or absent, or the quality of their presence or absence. The access to healthcare services, access to transportation, and we know that's kind of an issue here on the island if you are not using a car. There's quality of education and job training, so it's not just that we have access to education, but make sure that it's of high quality, and understanding that quality of education will matter because we kind of all get different quality of education in the context of the United States. So you must ensure people get the same return on their investment, particularly if they're coming to a university and paying tuition for their education. So what are some further examples? We might also consider things like public safety. So the level of crime that surrounds us, but also in that we also care about the perceptions of safety. So it's not just tied to crime reports, it's how safe do individuals feel. We might also then consider social support. So whether or not individuals, if they need, for example, clothing, shelter, money, is there someone to provide that material support for them? On the other hand, we might also consider emotional support. So if you are in distress and need someone to talk your problems through with, is there someone to hear you out and provide you that troubleshooting? We can also think a little bit more broadly in terms of prevailing social attitudes and norms that sort of impact us, not just here at the university, but everywhere in the context of the United States. And two of them that I like to point out is first, meritocracy, and it's pretty pervasive as an attitude in the context of this country, where we believe that the best will rise to the top, and as a consequence of that, if you are not succeeding, we sort of imply that it's your fault, right, or solely your fault. And thus, it's seen as a moral failing rather than a collective problem to be solved. We can also then consider, along the same sort of broader societal vein, the presence of discrimination along any dimension. So whether it be race, religion, gender, sexual orientation, disability status, et cetera, and its impacts on everyone who has to live on the receiving end of those discriminatory systems. And finally, when we consider, particularly in the context of the pandemic, we can see that trust or lack of trust in healthcare and educational systems and government more broadly has consequences for health. So we've made a lot of recommendations to how to mitigate the pandemic. We've recommended social distancing, masking, and getting vaccinated, and we have people who don't think that those are acceptable, and some people who go to the extreme to think that those are actively harming them to engage in those behaviors. So it's something we should keep in the back of our mind if we want to improve the social determinants of health. So why do we care, or why should we care about the social determinants of health? So I, as a public health scholar and practitioner, care about the social determinants of health because improving them is critical for improving population health and reducing health disparities and promoting health equity. However, not all of us are in that same boat, and not all of us have that same goal. If we aren't directly tackling the social determinants of health, understanding them will help us understand why disparities and inequities continue to exist, and why efforts that ignore the social determinants of health will be insufficient to improve population health. So even if it's not our direct task to tackle the social determinants of health, it's still helpful to understand how they play into what we ourselves are actually doing. So because of this should matter to us as educators in the audience and potential healthcare providers in the audience. So particularly in Stony Brook, why we should care. So education itself is a key social determinant of health, and SBU provides education to thousands annually. And important things we might consider here is who we teach, so who has access to our education, how we teach, and is it the same for everyone, or is it modified to meet individual needs, what we teach and what we don't teach, and how that potentially creates gaps that leave people falling through them, and what things cost in terms of the accessibility of our educational services. Similarly, Stony Brook Medicine is a large system, and access to our services is a social determinant of health for the local population. And important things to consider here would be what services we offer, what they cost, and where they are located. One of the challenges here on Long Island is that we're kind of far-flung. So individuals who are technically in our catchment area might have difficulty accessing our services. So why do we care about the social determinants of health as they pertain to health and well-being? And the answer to that is because they determine a good deal of health and well-being. And so here we look at broad categories of what contributes to health and well-being. And here we can see that the biggest contributor here is individual behavior at 40%. The next biggest category will be genetics. The last two categories combined are roughly the social determinants of health. So we have healthcare, and then the social and environmental factors. So about 30% of what determines health and well-being are the social determinants of health. So not something we could ignore. So how do we address or improve the social determinants of health? So one perspective is from Healthy People 2030 and their place-based framework. So they sort of argue that there are 5 big categories of social determinants of health and sort of strategies that we can invoke to address them. So the categories are education access and quality, healthcare access and quality, neighborhood and the built environment, social and community context, and economic stability. So I'll go through each of them in turn, giving some examples, however lofty they may be, about what we can do here at Stony Brook University to address them. So first, let's consider economic stability. Because as a university, we employ many people and we sort of provide a service of education to many students, we can make sure that we give additional access to jobs to folks, provide full-time employment as much as possible, and make sure that all of our employees have a living wage and have benefits that meet their needs. In terms of food insecurity, which still exists among our employee and student population, we can make sure that we have resources available to them and we reduce the stigma of accessing these resources for students in particular. In terms of something like housing instability, so some of our student population, and this is not unique to us, will be unhoused. And this is a national sort of crisis that goes largely ignored because of the stigma and shame surrounding this. So we can make it so that people feel comfortable seeking help, but also that there are more long-term solutions for those who find themselves unhoused. Next, we can tackle poverty. So reducing individuals and families that are below a certain poverty threshold, and we can do that by providing support not only directly, but there are federal government programs to assist people, and we can link them or assist them in applying to those services. In terms of education access and quality, we can actually run the gamut more than just looking at higher ed. Because at Stony Brook here we provide childcare for our employees, we can also improve the quality and access to that childcare for our employees to improve the lives of their children. In terms of enrollment in higher education, as our next speaker will discuss, we have many pipeline programs that go into communities to encourage individuals to enroll in higher ed, and we can continue and expand those efforts. In terms of high school graduation, so sadly we do have another crisis in the United States in terms of people dropping out from high school. So our pipeline programs can encourage people to stay the course there or provide support. And finally, in terms of education access and quality, is language and literacy. So not just enough to deliver a diploma, but to make sure that there are some solid, tangible skills attached to that diploma. Next, when we look at the social and community context, we can encourage civic participation among members of our community so that we can collectively work to improve our surroundings. So not just the campus community, but the neighborhoods around us as they exist. We can tackle discrimination as it exists within our community as well, to make sure that people stay at SBU and that they are happy. And that might involve difficult things like trying to hold people accountable who engage in discriminatory behavior. In terms of addressing the needs of unique populations, we have individuals who are impacted by incarceration. So they are people with potential convictions on the record or have family members who have been incarcerated. And we need to consider what we can do to reach those populations and incorporate them into our community. Next, we can improve social cohesion. So make sure that individuals within our communities are not feeling disconnected, that they feel like they have someone to trust on campus, as we know that those things are important to health. Next, if we want to shift our attention to what we can do on the healthcare side, there are also a few things. We can improve access to healthcare. So for example, we can encourage providers to take all insurance types so that they don't systematically exclude individuals based on the type of insurance they have access to. We can ensure access to providers and appointments in a timely manner, provide free care for those who cannot afford it, and maybe improve access to those who are in far-flung locations who can't reach us readily. In terms of access to specific services, we should highlight primary care as it is important in the preventative sense. Next, if we want to improve how our patients comply with our recommendations, we should also work to improve health literacy, to make sure that they can act on the information that they are given and actually improve their health because of it. Lastly, in terms of the neighborhood and the built environment, we can also work within our broader community vis-a-vis advocacy. So we can ensure that our communities have access to food that is available and appropriate for those around them so that it meets their dietary needs, whether that be determined by their religious background, their dietary restrictions because of health conditions, etc. We might also be concerned with tackling crime and violence in our surroundings to make sure that all students, staff, faculty, etc. are comfortable coming to our campus. In terms of environmental conditions, continuing efforts that have worked to improve lighting, build sidewalks, improve infrastructure, etc. And lastly, quality of housing. We house many people in our own campus in terms of student housing, but also encouraging vis-a-vis advocacy individuals outside of campus to improve conditions and lower costs for housing. So that is all I have. Thank you very much. I'd like to turn the floor over to Lisa Johnson.
Thank you, Dr. Alcala. Organizations which focus on creating an inclusive learning and work environment may promote greater retention of a diverse workforce, reduce costs related to attrition, and ultimately affect patient satisfaction and quality of care. There are many factors to contribute to inclusive learning and work environment. My focus today is to share some of the School of Health Technology and Management and the School of Medicine pathways for increasing a more diverse student population to pursue health careers, an initiative which address cultural awareness in Stony Brook University workforce, as well as the School of Health Technology and Management initiatives to address diversity, equity, and inclusion in health professional programs. Extensive research exists that diversity in health professions and have an inclusive learning environment for health professionals can contribute to mitigating health disparities. Patients with health professionals of the same race report a greater respect because what happens, they feel more comfortable communicating with patients that look like them, and there's more willingness to share their information to the provider. Diversity in healthcare professions improve health access and quality for underrepresented patients, strengthen healthcare delivery at multiple levels, enhances educational experience for health professional students, and promotes relevant research. Now, pathways to healthcare professions is easy. It's not a problem whatsoever. Have equal access to high-quality education provides the means for individuals to pursue a career in health professions. You have a pipeline for primary to secondary to post-secondary education, and then to professional health programs. So that's easy. That's how it should be, except for underrepresented groups. Underrepresented groups, including but not limited to physical ability, LGBTQIA+, age, gender, geographic location, race and ethnicity, in particular African American, Hispanics, and Native Americans, often do not have equal access to high-quality education at all levels. As a result, they do not flow equally through the pathway to health professions. So student pathway and internship programs that enhance recruitment of underrepresented groups can increase the likelihood of achieving a more diverse workforce. At this time, I now would like to focus on some pathway programs from the School of Health Technology and Management and from the School of Medicine, which provide collaborative opportunities with diverse health professionals, students, researchers, and scientists to expose, engage, inspire, and recruit underrepresented groups of students from high-needs high schools here in Suffolk County, local community colleges, as well as undergraduate and graduate Stony Brook students to pursue health careers. Health Occupation Partnership for Excellence Program, or HOPE, is a program for juniors and seniors from school districts of Brentwood, Longwood, and Wyandanch. And it's a 2-year program for the students who come here to Stony Brook University Hospital and the campus. And the focus is for academic development so they can pursue future careers in the health industry. These students have an opportunity to spend time with different health professionals and actually shadow individuals in the hospital setting. HOPE has been instrumental for launching the college careers of 196 young people who are interested in pursuing careers in health. Health Careers Opti program, Hcop, was a program that existed in the School of Health Technology and Management. It was a program that was for students from Amityville, Brentwood, William Floyd, Wyandanch, and the Southern Uncompahgre Nation. And the focus behind that program was enriching the students in terms of academic support, exposing to different types of healthcare professions, team building, college readiness, and career planning. Now, the program Hcop that existed here from 2009 to 2012, it allows students for 3 summers to come here for 6 weeks. They were juniors and seniors, and that enrichment program was more intense during this time frame, but was most important throughout the academic year. We would continue to go into the different high schools to provide this support. And this was under the guidance of the late Dr. Carlos Vidal. What happened was Hcop ended, we had no more funding, but Dr. Vidal was very important to us in saying that, you know what, we cannot stop going into these high schools. We have established the relationships and we have to continue the relationships. So from that point, he established Health Careers, Academic Readiness and Excellence, which is HCARE. So HCARE now continues under the Center for Community Engagement in the School of Health Technology and Management. So we still offer opportunity for students in grades 9 to 12 that are from the districts of Amityville, Brentwood, William Floyd, and Wyandanch. And we just recently had Riverhead School District join us as well. And we continue to provide support, academic support, expose them for different health careers, do team building, do college readiness, as well as career planning. Youth Enjoy Science Research Education Program. The YES program will be submitted to the National Cancer Institute, and the focus is working with high school juniors and seniors specific to cancer research. Biology Partnership and Research and Education Program, or BioPrep, is a program that is funded by NIH. It's a program for community college students who are underrepresented who wish to further their education and pursue careers in biomedical sciences. It is an 8-week summer program. Increasing diversity in undergraduate cancer education and research in DUSA. And DUSA is a program for rising Stony Brook College juniors. It's a 10-week summer program. And this 10-week summer research program on the Stony Brook campus, where students experience living, learning, and working at a world-class research institution. Pre-Medical Access to Clinical Experience, or PACE, which President McInnis mentioned earlier, is a program for junior and senior Stony Brook undergraduate students who have self-identified as pre-med students. These students have the opportunity to shadow Renaissance School Medicine and faculty members in private practices and in the hospital in order to increase their exposure to clinical experience and their ability to successfully apply to medical school. Some of the things that the scholars participate in is how to study, professional communication, professional etiquette, and how to write a personal statement. Stony Brook Underrepresented Pre-Med Scholars, or Supremes, is a program that augments the Scholars in Medicine program. And the focus behind Supremes is to increase diverse population of physicians and physician scientists. A program that's currently under review, Minority Access to Research, or MARC, is looking to be funded by the National Institutes of Health, and the focus is for undergraduates, juniors, and seniors. There are other additional undergraduate programs here on Stony Brook campus. There's no way that I covered all the programs, so there's a lot more that exists here on campus. And some of the programs that I have had an opportunity to work with, as well as some of my faculty from the School of Health Technology and Management, is CSTEP, EOP AIM, and WISE. Responding to Equity, Diversity, Inclusion, which is READY, was a program that was in existence from 2016 to 2018 and was open to all Stony Brook staff. It was a program that was developed and facilitated by Robbie Kincaid from the School of Health Technology and Management. And the goal was to introduce participants to the concept of privilege as it relates to race, ethnicity, gender, sexual orientation, gender identity, physical and mental disabilities, socioeconomic status, and how the aforementioned has the impact on the organization's environment. This was a 7-hour experiential workshop that was a psychologically safe and brave space. There were more than 1,000 Stony Brook employees that had attended, and the groups were kept to less than 20 per session. A few colleagues in the School of Health Technology and Management came together over the years in friendship, which gradually morphed into mentorship and support. When the social injustices were on the rise in 2020, we came to our dean, Stacy Gropak, to share our concerns. After several meetings with her, she responded by appointing a director of diversity, equity, and inclusion that we now have in the School of Health Technology Management. The focus is to create a culture of inclusion and social justice within SHTM by recognizing its diversity and addressing mechanisms of systemic bias that affected marginalized groups. The aim is to foster growth and advocacy for all members of the school. The Office of Diversity and Equity in SHTM distributed a climate survey to the faculty and staff. The data from the survey is currently being analyzed at this point in time, and these results will help us to drive initiatives for professional development. We have worked on and created a DEI statement, which is now required to be in all of our course syllabi. And we continue to look at our admission process to make sure that it's an equal opportunity for all individuals who apply. And we're also looking at different ways that we can engage our students, which is extremely important. So I've taken the time to share with you that it's important to have different high school pathways that can lead to health programs. It's important to have different programs within the colleges we have here at Stony Brook, but it can't stop there. It has to continue in the classroom setting. We have to look at having inclusive learning in our classroom settings as we are working to educate future healthcare professionals. And if we continue to do inclusive learning within our classrooms, we then will educate and then graduate future healthcare professionals who will go out into the workforce. And if we do this, then these individuals will be stronger together in eliminating disparities in healthcare and health outcomes. Thank you. I would like now to introduce Dr. Adam Gonzalez.
Thank you, Lisa. It's an honor to be on this panel today and alongside some wonderful colleagues. So I'll be talking about some of the initiatives that we have going on at Stony Brook Medicine to promote diversity, equity, and inclusion. Before getting into the initiatives, I just wanted to highlight a couple of important definitions here that we can keep in mind as we approach and interact with one another and also think about our DEI efforts. So the first here, cultural sensitivity, which is learning about and understanding people who are different from ourselves, thereby becoming better able to serve them within their own communities. So really becoming knowledgeable about who we're interacting with. And perhaps one way that can help facilitate that is cultural humility. So cultural humility is a lifelong process of self-reflection and critique where we can learn about another's culture, but first we really have to take a deep dive into reflecting on our own beliefs, our own cultural identities. So when we can get a good sense of who we are, what makes us special and different, we can then develop a greater appreciation for others and be able to better serve others where they're at. So the work that we're doing is directly in line with President McInnis's vision of One Stony Brook. So really working with all of our other hospitals, Stony Brook, Southampton, ELI, as well as the university. Super grateful for our Chief Diversity Officer, Dr. Judy Brown-Clark, and her office and her support in a lot of this work. In addition, and what's not pictured here, is also our ambulatory practices and community practices. We're really trying to engage everyone across our health system with the goal of creating a safe, welcoming, creative, and stimulating environment for all. So we have lots of different initiatives going on. These are 3 that I'd like to highlight today. In addition, and one that I'll mention briefly, is we have a really amazing graduate medical education committee that's focused on DEI efforts. And over the last couple of years, we have seen great participation by our residents and fellows coming up with really exciting ideas to move things forward. So I'm really proud of that group as well. So I'll be talking about LGBTQ healthcare equality, and that asterisk there is to represent the fact that we support and welcome all sexual orientations and gender identities. I'll also talk about diversity ambassadors and diversity strategic plans. And then I'll end with talking about a new proposal that we've just put forth and are having active discussions with all of our health partners, systemically targeting oppression in medical practice, also called STOP. So our Stony Brook LGBTQ committee started several years ago. In addition to myself, our co-chairs are Rose Carden, Director of Patient Education here at Stony Brook University Hospital, and Dr. Allison Elliskew, our Division Chief of Adolescent Medicine. We also have amazing participation from leaders, again, across our health system. So Robert Ross from Stony Brook Southampton, Jessica Marangio, Janet Jakowski, and Susie Marriott, Chief Nursing Officer at Stony Brook ELI. Also Ann Walsh-Feeks from our ambulatory practice, so we're really grateful for her participation as well. And then also leaders from our IT, communications, and marketing teams. So we're really trying to engage and bring everyone in to help move these initiatives forward. So our mission is directly in line with Stony Brook Medicine's mission to deliver world-class compassionate care to our patients. And these are some of the main objectives as part of our committee that we seek to focus on. So why does this all matter? LGBTQ individuals face many barriers to care, including insufficient provider knowledge, negative provider attitudes, stigma and discrimination is still high for this community, and we see great healthcare disparities, and there are also a lack of appropriate health education. And here are just a few stats that really highlight and underscore the importance of focusing on this community and really improving our systems to provide the best care possible. And in doing that, really proud of this accomplishment here. The Human Rights Campaign is one of the oldest and largest LGBTQ advocacy organizations, and they put forth this Healthcare Equality Index. So in 2020, both Stony Brook University Hospital as well as Stony Brook Southampton Hospital achieved the designation of Healthcare Equality Leader. We just found out actually last Friday, so some of our leaders might not even know this just yet, but Stony Brook University Hospital just received the redesignation as a leader status for 2022 to 2023. And we're waiting to hear back about Southampton and also ELI, who submitted their application the first time this year. So just to give you a context of what some of the numbers are as part of the Health Equality Index, there are 765 participating organizations throughout the country. Of those, 65% hold the leader designation status as we do. On the right-hand side here, you'll see a screenshot of the Northeast. So in New York, there are 78 other organizations that also are leaders. So why do we participate in the Health Equality Index? For lots of good reasons, not just for the notoriety of being named a leader, but really because we want to be at the top, the best gold standard practices for our LGBTQ community, not only our patients, but also our employees. So it really pushes us to look at what are our policies and procedures, what resources do we have available, again, not only for patients, but for our employees, staff, and trainees, making sure that we can provide the best care possible, and with the end goal of improving quality and safety. So what are we doing here at Stony Brook Medicine? Again, our IT team has been a great support in this initiative, pushing Cerner to make some of these updates as well system-wide. So we're now able to differentiate between birth, sex, and gender identity within our EMR. We're able to have patients list out their chosen name, which can be seen on the banner bar. We're also able to have pronouns be listed in the EMR as well. Some of the other key initiatives, and I'll show you some of the screenshots of this work. We have our LGBTQ care website. We've looked at and are continuously updating our hospital policies, having signs at reception areas, updating bathroom access and signage. So we were able to convert over 70 single-stall restrooms to gender-neutral restrooms. Also, a great thank you to Carol Gomes, our CEO, who's been incredibly supportive in having us submit this application, as well as making a lot of these updates and changes at our hospital here, and LGBTQ training. So we're really working to offer cultural sensitivity trainings to all of our employees as well as trainees. This is a screenshot of our LGBTQ care website. If you haven't seen it, I encourage you to take a look at it. We really love our Brady Bunch picture here on the cover. There's lots of great resources. Under patient care, we have providers that have self-identified as having expertise in providing care to the LGBTQ community. We also have videos of our recent transgender health conference that took place last year. Another piece on our website that's not shown here is our recent Stony Brook Out and Proud list. So this is a place where our employees, faculty, staff, trainees can actually identify themselves as being part of the LGBTQ community in an effort to promote community and also to show that as an organization we really support our employees and are proud of them. This is a screenshot of the welcome sign that we've rolled out at all of our ambulatory care practices. And so this serves as a visual representation of being a welcoming and an accepting place for all patients. So it encourages patients to share their name and pronoun. Now we have ways within the EMR to actually capture that. Most recently, we just wrapped up the first of its kind LGBTQ comprehensive health needs assessment that occurred throughout all of Long Island. So this initiative was led by our planning team, led by Jen Jemikowski in partnership with Stony Brook Southampton and the Edie Windsor Healthcare Center, as well as over 20 community partners. So we're really excited to be able to take a look at this data and to better understand what are some of the unique problems facing the LGBTQ community here on Long Island. So then we can go on to develop a strategic plan to start addressing some of these health disparities faced by this community. Lastly, in this area, I'll just highlight the Edie Windsor Healthcare Center, which recently launched and again, one of its kind, first here on Long Island, as a comprehensive LGBTQ care center in collaboration with Stony Brook Southampton Hospital. So we're really excited to have this be part of Stony Brook to provide comprehensive care to the LGBTQ community. So switching gears a little bit, the next initiative that I wanted to talk about is our Faculty Diversity Ambassadors Council. So this council started several years ago. My partner on this is Ms. Inel Lewis, who's the director of Stony Brook Medicine Diversity Initiatives, and has been a great support in this area. So all of our departments throughout the School of Medicine, we have diversity ambassadors representing each department. And then most recently, we've included representation from our various health schools, as well as Stony Brook, Eastern Long Island Hospital, and Southampton Hospital. So the ambassadors serve as a liaison between the department and the council with the goal of executing the vision of creating a diverse and inclusive academic community. They provide the administrative oversight to bring this vision to their department and work closely with the department to organize and execute different initiatives. Many of the departments have gone on to develop diversity subcommittees within the department to help brainstorm and come up with various diversity, equity, inclusion initiatives for their department. And importantly, they're also charged with carrying out the development and execution of a departmental diversity strategic plan. So this strategic plan is a way to hold ourselves as well as our departments accountable for really embracing diversity, equity, inclusion as we do as a whole here at Stony Brook. They also work with the department chair to monitor and report on these initiatives and strategic objectives. Again, our Chief Diversity Officer has developed a really great website here, and this is a screenshot of one aspect of the website, which is a DEI strategic planning toolkit. So it actually has resources available that can help guide the departments and the schools in their efforts to develop a strategic plan focused on DEI. And what's great that it's publicly available, this also serves as a resource perhaps for others and showcases, again, our commitment to diversity, equity, and inclusion. One last accomplishment that I'll point out as part of the Ambassadors Council is we recently revised Stony Brook Medicine's campus description. So this is the campus description that's included in all of our job postings. And specifically here in bold, we added a statement on diversity, equity, inclusion to highlight the importance of this as an institution. And my hope is that this will be one of many initiatives to look at our public as well as our internal facing documents to make sure that diversity, equity, inclusion, and our commitment to these areas are interwoven throughout everything that we do. And the last piece that I'll talk about is this initiative here, which was spearheaded by Dr. Will Farguson in the Department of Psychiatry. We've worked closely on with our various partners to put this together, which is systemically targeting oppression in medical practice, or STOMP. So we know, and as we heard from others, that healthcare disparities exist, and racism, discrimination, biases can be key drivers of healthcare disparities and affect those who seek treatment. One area that has perhaps been less focused on is the fact that healthcare workers at all levels are subjected to the experience of oppression, racism, discrimination, and also various biases by our patients and also by perhaps colleagues, fellow employees, and within medical practice more broadly. These experiences can be traumatic. They can evoke strong emotional responses, create a hostile work and training environment. They may negatively impact patient care, recruitment of new employees, and may also lead to burnout, which is important. So STOMP is meant to be a system-wide collaborative effort directly aligned with Stony Brook Medicine's eye care values noted here. And the purpose is really to develop a systemic approach aimed at eradicating discriminatory, oppressive, and hateful actions within medical practice. And so we've been engaging all of our key stakeholders throughout all of our patient-facing groups, as well as on the university side. And again, our Chief Diversity Officer is a major part of this work. So the initiatives here will focus on increasing awareness and education about oppression in medical practice, looking at and improving our systems for capturing these events, and importantly, providing support to employees who are subjected to these experiences. Targeting perhaps that first piece around the patient experience and the patient's experience of discrimination, the Joint Commission recently put out this initiative called Speak Up Against Discrimination. And so we're looking into adopting this initiative as part of STOMP to help promote and empower our patients and their families to speak up when they're experiencing discrimination. The other aspect of STOMP is really focused on more of our healthcare workers and our employees to make sure that we have a safe and welcoming environment here at Stony Brook. So we've identified some of the stakeholders, the key stakeholders at play, and started meeting with various leaders, and also some of the pre-existing resources and supports that are available. And so we'll be looking at ways to perhaps enhance some of the resources that we already have available here in order to provide support and also collect data on these oppressive experiences. We recently wrapped up the Culture of Safety survey, so we'll be able to look at some data to help drive our initiatives moving forward. So thank you for your attention. Here is the Stony Brook Diversity website, again, from our Chief Diversity Officer's office. So I encourage you, if you haven't taken a look at it, please do so. There's lots of great resources there. Thank you.
Okay, thank you, panel. I think that this was a great presentation by everyone. And I thank you for presenting. I hope that you take something away from this in the fact that this is a dialogue that needs to be continued, and hopefully we can all do that. Right now, we are opening this up for questions, if anyone has any questions.
I'll take the perspective of some of the clinical faculty who I think don't necessarily know how to begin in the context of their own practice, say dealing with some of the social determinants of health. How do they overcome some of the issues that people who aren't even their patients, who could be their patients, are facing? Or some of the things that their patients are facing that they don't really have the tools to address. What sort of advice can we offer those clinical faculty to try to improve what they do?
Yes. So that's a great comment and question. So when I talk to residents, I tell them, I know that this is not necessarily part of your job, and that me asking you to do this is overwhelming. It might seem unfair. You might want to ignore me. But at the very least, what you can do is know who to refer them to, whose job it is to tackle these things. And oftentimes that is our colleagues in social work. So we can refer them and train our providers to refer them to social workers who are trained in providing these supports and tackling the social determinants of health more directly. So yeah, I think it's helpful for our providers to get trained, but understanding that, that is a long process, and that your time is, highly valuable and already taxed with all the million other things we want you to do. So at the very least, we should be able to turn people to social work or other colleagues to have their issues met.
But can I also point out that this shouldn't be something that's voluntary and someone needs it only when they are facing issues. I think this is something that we as an institution should promote up front so that this doesn't occur, it doesn't happen, it doesn't need to be addressed. Show of hands, who all like this?